Good. Shall we start then? Well, good morning again, and it's very nice to meet everybody. Nice to be here. It's a fantastic country. So from UK, grey, listen to this, 0 centigrade, freezing temperature. And now sunshine, warm. I feel a bit too hot. Disgusting thing. Oh dear. Okay. I'll cope. I feel like Madonna with this on. Dreadful. So my name is Marcus Drake. I'm Professor of Neurological Urology at Imperial College London. 4 months ago, I was Professor of Physiological Urology in Bristol. So it's a big change to move to London. But the reason to go to London is because the urodynamics area is very weak in the UK, in Europe, in the world, despite the huge impact that this has on our patients. And within London, we have the academic strength to start to push home some of these incredibly important messages that there are for the patients. And within us as healthcare professionals, we need to be waving the flag to do a better job. Amongst our colleagues, we must improve how these patients are looked after. And we'll start with the basic one here, which is the terminology. How do we describe these conditions to our patients within the profession and this sort of thing? Now, this area does confuse people a bit, but actually the logic is quite simple. And one thing that we identified was the importance to have clarity and easily accessible free resources. So in 2018, we published this supplement in Neurourology and Urodynamics, and the link is here. And we can circulate this as a PDF afterwards so that everybody can get this link, because this is the contents. It's a sequence of articles which is about simple message, what you need to know. And it's, I suppose, an apology, because the International Continence Society has published many documents, but they're huge and they have so much information that actually it flies over your head and is impossible to understand. This is the basic information, the essential. And so, as you can see, there's a terminology document. There's one for neurourology. There's one for pelvic organ prolapse, flow rate testing, and this for today's course, the basics on urodynamics. So some reading for another day. Now, the key way that we look at the lower urinary tract function is to split the activity of the bladder and the sphincter into 2 phases, which is the storage phase, where you hold on to the urine, and the voiding phase, where you expel it. And that translates into the symptoms, the storage symptoms, and the ones that happen during voiding or immediately afterwards. Definitions were derived, and the ICS published the definitions of the various key symptom complexes. And that's then led to this sequence of key papers, which includes the standardizations of the International Continence Society, which is the authoritative statement of what we're referring to. And then the authoritative urodynamics statement, and then subsequent important things. Now, to think about the storage symptoms, we need to be quite clear exactly what we mean. For example, if we say somebody has urgency. Now, I think most of us can understand urgency when we hear a patient describe it. Ooh, I've got to go, or I'll leak if I don't quickly get to the toilet. Now, the phrase that we use to describe that as a standardized term is sudden. You know, it's quick, compelling. You have to go to the toilet. It's not a choice. If you don't go, you've got a problem. And you really can't put it off. Now, the next symptom is increased daytime frequency. And that is referring to a sensation or a feeling that you go to the toilet too often. And the correct term is increased daytime frequency. Please don't simplify it as the simple word frequency, because frequency is how often you pass urine. If you have kidneys and make urine, you will have a frequency of voiding, and it can be absolutely fine, or it can be increased. So the symptom is increased frequency, whereas how often you pass urine is just an observation. It's really specific, exactly, because then the night time is waking at night to pass urine. So we can put these together to give us the important symptom complex of overactive bladder syndrome. And that is defined by urgency. This person has to have the sudden, compelling desire to pass urine. It could be with incontinence. It'll usually be, now, here they made a mistake in the original definition because they said frequency. They should have said increased daytime frequency, usually with increased daytime frequency and nocturia. And of course, you need to exclude urinary tract infection, which is an inflammatory process leading to increased sensation. Now, in a urodynamics course, we've actually got to be extremely specific. OAB refers to the patient describing urgency is present. That is not the same as overactive detrusor or detrusor overactivity. That relates to the urodynamic observation of pressure changes during filling, which might be neurogenic in origin, meaning that there's a relevant neurological condition. Now, to emphasize the specificity of the terminology here, we did a diagram which was in Campbell's Urology to illustrate these various symptoms and how they could be put together. And then you can say this big green circle with the U is for urgency. So these are the OAB patients. Some of those patients have incontinence, urgency, urinary incontinence. That's these. They are a subgroup of overactive bladder. You could call them OAB wet. Now, usually these OAB patients have increased daytime frequency. So there's a big overlap. Many OAB patients have increased frequency, but not everybody with OAB has an increased frequency. And then there are quite a lot of patients who describe going often, but who actually never experience urgency. Now, I'd be interested to know what people think might be happening for that particular patient. Are there any thoughts from people? Why might people get an increased daytime frequency and yet not have urgency? That's a question to you. This is an interactive course. Thank you. Why might somebody have increased frequency but not have urgency? Sorry, who said? Polyuria, absolutely. So they are making too much urine, so they have to go often. So they have an increased frequency, but it's not urgent. Absolutely. That's one mechanism of polyuria, is high fluid intake. So I completely agree. Yeah. What might underlie that sort of situation? Physiological or pathological? So I guess the increased fluid intake would be physiological, increased urine production rate, and then there are other mechanisms of polyuria, like poorly controlled diabetes, that will also raise frequency. But there's also increased sensation, like pain. You can have pain that makes people want to go to the toilet, and that's not the same as urgency. They go to the toilet because they're trying to eliminate pain, but they don't have urgency to do that. And so it's quite important with our OAB patients, particularly where frequency is high, to get a bladder diary to eliminate polyuria, but also to ask, why are you going to the toilet? And then they might be clearer. They might say, I'm worried I'll be incontinent. Then you really are talking overactive bladder. Or they might say, because I have discomfort or whatever. Important to get this explanation. So alongside the OAB, these patients, we have the detrusor overactivity. Now, there is clearly an overlap between detrusor overactivity and OAB. You can see the circles are quite close together, but you will see in urodynamics, some people get pressure change during filling, and you ask them, are you feeling anything? They say, no. Why do you ask? The reason you're asking is there's a big change in pressure. That is detrusor overactivity. They do not experience urgency in the daytime, or indeed urgency during the urodynamic test whilst overactivity is happening. And that would be these patients. They're not the same term. So there are two important things when it comes to this group. One is to say, where is this a common observation? And again, that's a question. If you're doing a urodynamics test, which are the patients that are most likely to have detrusor overactivity but no urgency? Which patients? Neurogenic. It's the neurogenic patients where the sensory information from the lower urinary tract is finding it difficult to make it all the way up to here. Here is the consciousness location. If the signal gets blocked here, they'll never get the sensation of urgency, but you are looking at the detrusor overactivity. So it's common in neurogenic patients. Now, separately, you do find some people, and it's more women than men, who experience detrusor overactivity, and yet they are not describing urgency. Now, I guess that would be a question. Are you a gynecologist? Fantastic. Very welcome. I guess a question to gynecology is, you'll often do urodynamics for women who describe stress incontinence. And if you do urodynamics for stress incontinence, but find that as well as the stress incontinence, there is detrusor overactivity, but they're not feeling urgency with it. My question to you is, does that matter? Do you actually care? Well, overactivity, no sensation. It's a trap question. So before you answer, I might rephrase it as, why is it important to make it very clear? How would you counsel the patient if you see this? No, you won't. Well, what will the urologist do then? You don't want this question. So I guess what I'm getting at is, if you've seen stress incontinence, you might start to think about surgery for stress incontinence. Now, if you're thinking surgery, does the detrusor overactivity matter? Well, you have to be concerned that when you do the stress incontinence surgery, this detrusor overactivity then becomes highly symptomatic. So asymptomatic detrusor overactivity, you do something. We did not bother to report it because it did not give the patient symptoms. No, the urodynamics is a predictive test. It predicts outcome of surgery. So if you see stress incontinence, you can predict that stress incontinence surgery would be useful. But if you also see detrusor overactivity, you can counsel the patient, hey, if we do stress incontinence surgery, it might sort out that problem, but you might get a new problem of urgency incontinence. And as gynecologists, you will be well aware of stress incontinence surgery patients who come back with urgency incontinence and are very unhappy. So this asymptomatic detrusor overactivity is a crucial observation. It is perhaps why we do urodynamics for stress incontinence, because it's easy to diagnose stress incontinence on physical examination. Look, cough, leak, you have stress incontinence. Why do urodynamics? Because of that. Now, the final circle is the nocturia. And I've put the big space of nocturia is nothing to do with OAB. It's entirely due to what you mentioned, excess urine production, which might be happening only during the night. And that could be evening fluid intake, or it might be heart failure, or it might be sleep apnea. In those conditions, there's no urgency, and so that would be nocturia without OAB. Clear with this? So here is the formal definition of detrusor overactivity. It's a bit wordy. Pressure change during bladder filling is enough. It might be spontaneous. It just happens during the filling. Or provoked. You might trigger the overactivity by asking the patient to cough, or putting their hand in cold water, or the sound of water trickling into a pool, like turning on the water taps. That can trigger this. And in the past, it used to be said that it had to be at least 15 centimeters of water in amplitude. That's no longer the case. There's no amplitude, no minimum amplitude now in the definition. So here we have our first urodynamics trace, and we're going to illustrate detrusor overactivity with it. So what we are looking at, this is the water that's been put into the bladder. You can see that actually we've plotted just a bit of the trace because the bladder's already reached 140 mils of filling here. So the test started over here. You can see that we're recording abdominal pressure and we're using a rectal line to do that. We're recording vesical pressure, and the computer is calculating the difference between the bladder and the abdominal pressure to give us what the detrusor is up to. So here you go. Overactivity. Characteristically, it starts, it builds up, it declines. We call that phasic. Phasic contraction. And it comes back. And it comes back quicker and more powerful. And the more the filling, the more often these are happening and the stronger they get. And eventually you get flow. Now, flow during the storage or the filling phase, by definition, is incontinence. So this is detrusor overactivity incontinence. Quite easy. But interestingly, we did a big study in the UK and audited the diagnostic accuracy of urodynamics tests and found that 40% of the units actually got detrusor overactivity wrong. And I just couldn't work out why they were saying detrusor overactivity or why they did not. But actually it's simple. Phasic changes in pressure, here they are, and sometimes there will be incontinence. It's not difficult. So the detrusor leak point pressure relates to somebody with impaired compliance, and we'll be looking at impaired compliance during the neurogenic talk. So there, you do have a detrusor overactivity leak point pressure, but that's not actually the same. But basically, if you wanted a detrusor overactivity leak point pressure, it's basically the pressure where the leakage happens. So here's the leakage. And you follow the line, and this would be the, well, that perfect, perfect. Correct. So the detrusor leak point pressure is a phrase that does not apply in this trace. And we will look at the detrusor leak point pressure when we come to the neurogenic talk, because there's impaired compliance. In the overactivity situation, there is a detrusor overactivity leak point pressure, which is, here's the leak point, the start of the leak, and you follow that line and you see a pressure there. And you could call that the detrusor overactivity leak point pressure. But it's a very difficult concept because the leakage will happen at really very varied pressures, because it depends on how strong is the sphincter, how tired is it, how much work has it been doing. And that's a bit like if you go to the gym, you'll perform better if you've had coffee and rest, and you will perform worse if you've been operating for 8 hours. It's very varied. What's your performance in the gym and it's very varied. What is the performance of your sphincter during this test? So you can't actually get a consistent response from the same person, let alone from different people. So, but we will cover detrusor leak point pressure during the neurogenic talk. Okay, so incontinence falls into various categories: stress, urgency, and mixed urinary incontinence. Stress incontinence is related to effort or exertion. Urgency urinary incontinence is related to urgency, and mixed urinary incontinence, both features are present. And that is different from this mixed incontinence, because that, and that will again be relevant in gynecology, refers to urinary with fecal incontinence. So if you're talking about stress and urgency, then the phrase to use is mixed urinary incontinence. Okay, so back to your point about polyuria. Formally, the definition is 40 mils per kilogram per 24 hours. Now, in the UK, the average weight used to be 70 kilograms. I'm not 70 kilograms. Not many people in the UK are 70 kilograms anymore. But that means that basically, if they pee 2.8 liters in 24 hours, then they've got polyuria. And I do have polyuria, and the reason is I don't think it's related to this. However, if there's a lot of sugar and I'm diabetic, it's related to this. So as soon as you meet somebody who's got polyuria, your first question is, do you drink a lot? And if they say yes, your next question is, why do you drink a lot? Now, you will sometimes, especially in the UK, get the answer, oh, I know I don't drink enough, so I drink as much as I can, but I know it's not enough. So it's like, oh, what? There's a health craze nowadays, probably driven by bottled water companies, to say drink more because you don't drink enough. What a stupid thing to say. So the result is people target having nice clear urine when they go to the toilet, and then they see that there's a hint of color and they think they're not drinking enough, so they drink more. Now, that's actually a very bad idea, because the high throughput of water through the kidneys washes away the concentration gradient within the kidney in the loop of Henle, in the pyramid. Therefore, they lose the ability to concentrate their urine, and therefore they start to not reabsorb fluid that they filter, and so they actually lose urine, and they have to drink to make up for the urine that they lose. So they end up with this vicious cycle where they drank away their concentration gradient, so they can't concentrate their urine, so they have to drink in order to make up for the fluid that they lost. Oh, so in the UK, probably about 4/5 of the polyuria cases are like that. They've drunk too much because they thought they were being healthy, but actually they were badly advised. Now, the other 5th, the rest of them, they drink because they are constantly thirsty, and they are constantly thirsty because they are losing fluid because they have a medical problem. It might be using a diuretic, or diabetes insipidus, or badly controlled diabetes mellitus, or something like that. In those patients, it's not appropriate to advise fluid restriction. You would advise fluid restriction to the first group, but not to the second group. Because if you fluid restrict somebody who has got water losing medical problem, then they go dehydrated, hypotensive, and hospitalized. So don't fluid restrict if they drink because they are constantly thirsty and meaningfully thirsty. Is that a similar situation here? Do you encounter that problem here? Really important. You are seeing it. There's a lot of overlap around the world. This is so are people advised to drink more and more and more? It makes some sense in the urology clinic. Yes, because of stones. Yes, absolutely. So a stones patient with polyuria is a very difficult patient. So then you have the nighttime situation of nocturnal polyuria. That's expressed as a proportion, not as an absolute number. And it's where more than a third of the 24-hour urine production happens during the sleep time. So when you look at somebody with nocturia, they're waking at night one or more times, and each void is preceded and followed by sleep. Of course, the void when you get up in the morning, that's not followed by sleep. So it's not nocturia, but it is involving the passage of urine that the body made during the nighttime. So it counts as part of the nocturnal urine production. So we can look at a diary and work out what's going on. So perhaps take a minute to look at this diary and decide what you think might be present here. Just to make it a bit clearer, these arrows indicate, or lines indicate, when they woke up in the morning and when they went to sleep for bedtime. So if you focus on this 24-hour period, okay. I guess the first question is the voiding frequency. Let's choose the voiding frequency. So voiding frequency in the daytime. So on this first day, day started with waking up and concluded with sleep time. So the voiding frequency in this daytime would be these voids. So just to be clear, this is a void, urine output, and this is the sensation associated with it. So these are daytime voids. So the daytime frequency on this day was 1, 2, 3, 4, 5, 6, 7. 7 voids in the daytime. During the nighttime, did they have nocturia? Well, they're quite clear. They went to sleep here. Sleep. And that therefore means that this one was preceded and followed by sleep. So was this, and so was this. This, therefore, is their nocturia 3 times that night. This void goes with the following day's daytime frequency. So daytime 7, nocturia 3. That's the frequency. And then there's the 24-hour voided volume and the nocturnal polyuria index. So what is the 24-hour voided volume for this period? Well, you would not count this one because it was made during the preceding night. So you would start with this voided volume and you would add this, and this, and that gives you the 24-hour volume for that period. So it's, I mean, rough mathematics, each one is about 200. So you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's about 2 liters. So this person does not have 24-hour polyuria. And what about the nighttime? This is part of their nocturia. So is this, so is this, and so was that. So it's about 800. So nocturnal polyuria is 800 mils. And to get the nocturnal polyuria index, you would express 800 mils as a fraction of 2 liters. And that is more than 1/3. So technically, this person does have nocturnal polyuria. You can't really explain why they have nocturnal polyuria, though you are interested perhaps in the fact that they had some fluid intake, which included wine, decaffeinated coffee, but it's only 400 mils. That's probably not the whole explanation. So you would need to do the medical history in order to work out why this is happening. This diary is the ICIQ bladder diary, and it's useful because it has sensation scales. So bladder sensation, it's done according to this scale. This is the only validated diary. It's a 3-day diary. I know I've only shown 2. It's a 3-day diary, and it's good practice that perhaps if you introduce this into your hospital practice, the ICIQ diary. And it's an interesting observation that there's some 2s happening overnight. Now, 2 means did get a bit of urgency, but it passed away. 3 means urgency, had to rush. 4 means urgency, incontinence. So the person is getting a little bit of urgency, and it's at a relatively small volume, 200 mils, having to go to the toilet. That's a bit small, isn't it? So I think you might be suggesting that this person perhaps has got a bit of overactive bladder. There's an interesting observation as well, the 0. This is a useful one. I like the 0s. 0 means didn't actually have a feeling of needing to pass urine, but went anyway for practical reason. So a very good practical reason is, I'm about to go to bed. I don't want to be interrupted by needing to pass urine, so I'll go to the toilet to try to prevent being woken up. So you do often see a 0 against voids at bedtime. People will also void without the need or feeling because they've got a meeting or a journey or something like that. And it does show up nicely. So I'm sure we all agree frequency is 7, nocturia is 3. We add up the fluid intake and we come to 2150. The 24-hour output, surprisingly, it really was very close to 200 mils per void, wasn't it? 890 overnight. So the actual number is 0.43 is the polyuria index, nocturnal polyuria index. I hope people do use bladder diaries for their LUTS patients. Yes? 1, 2, 2? What? Come on. This is standard assessment practice. You know how to interpret them, so I'm sure you do. So, but this is standard of care for EAU guidelines, is the bladder diary is essential for storage LUTS. For the voiding LUTS, these terms are a bit more simple. Slow stream, intermittent stream, hesitancy, and this sort of thing. But I think perhaps the important message from this slide is, look at this phrase, slow stream. Now, that's incredibly specific. It's exactly what you see. Somebody does a flow test and it comes out slowly, then it's slow. But disappointingly, very common and led by the Americans, who should know better, you see phrases like obstructive flow. Now, why do I criticize that phrase? How simple is that? It's obvious, isn't it? But urologist, perhaps gynecologist, looks at the stream and says, you have an obstructive flow pattern. The patient will immediately think that you know the mechanism of their slow stream and that it's obstruction. And they will look back at you and say, I would like you to relieve my bladder outlet obstruction, please. And so you've leapt straight from a simple observation that it's a bit slow to an assumption of mechanism that is completely unjustified, because the slow stream might reflect that when they did the flow rate, they didn't have enough volume in their bladder, so they did not perform well. Alternatively, maybe they have underactive, weak bladder contraction. Neither of those do at all well with surgery to relieve outlet obstruction. It's a catastrophe. So it's very easy. You have a slow stream. You say that to the patient, they say, why do I have a slow stream? And your response is, let's look into this and find out. How easy is that? Contrasted with, you have an obstructed stream, then I want you to relieve my obstruction. Don't. The rest of this, I think, is quite simple. So, mechanism. Bladder outlet obstruction, detrusor underactivity. And these can apply to women and to men, both terms. Outlet obstruction is high pressure and slow flow. Underactivity is low pressure and slow flow. Very, very easy. Now, defining those is very different between men and women. And for the men, we will discuss the definition of bladder outlet obstruction when we do the male LUTS talk a bit later. But for women, it's less standardized. You all three gynecology? And is anybody else gynecology? 3 women gynecologists and large numbers of male urologists. I detect a sort of trend here. But for women, how do you define bladder outlet obstruction? Do you have a definition urodynamically? I agree with you, no, because it varies so much from woman to woman. But there is a practical solution, which you can easily remember. There was a study by a scientist called De Freitas, and he looked at a lot of women with various causes of bladder outlet obstruction and came up with a beautiful, simple description of outlet obstruction, which is a pressure of 25 centimeters of water or above, achieving a flow rate of 12 mils per second or slower, means that she has got bladder outlet obstruction. 25 and 12. Memorize that, and you can be confident about diagnosing urodynamic bladder outlet obstruction in a woman. Quite easy, isn't it? So I love that paper because he looked at various studies. He found them all a bit inconsistent. there was a lot of discrepancy between them. And then he said, so why don't we just work out something that's easy to remember? 25, 12. Pressure above 25 with flow below 12 obstructed. In 1 minute, you can now diagnose bladder outlet obstruction in a woman. And it really is very useful. So the post-micturition symptoms, post-micturition dribble. Now, for the male patients, that is usually urine pooled in the urethral bulb. For the female patients, it might be urine that refluxed into the vagina and so comes out after the conclusion of the void. It's a bit unusual in women. And then sensation of incomplete emptying. Neurogenic. Now, we did a big exercise to look at the terminology for neurogenic lower urinary tract dysfunction. There was obviously enormous overlap with the neurogenically normal population. With urgency, OAB, incontinence, the definitions are the same. Likewise, stress incontinence and urgency incontinence. But there were situations which don't apply to the normal person. Now, these terms relate to an unusual but very clear situation. Imagine that you are talking to a patient in clinic and suddenly, whilst in the conversation, still in their everyday clothes, without any sign of distress or awareness of this is strange behavior, they pass urine into their clothes. Like, here I am, I'm talking to you, and suddenly you just pass urine. Unusual? Not unusual. You do it all the time. Well, you handle it very well, but it is quite unusual. And it usually reflects that there is some problem where they're not aware of the social appropriateness of behavior. So it's usually a feature of dementia or a cerebral dysfunction. So we call that voiding dysregulation. In other words, the void was entirely normal, but the circumstances were not at all abnormal. So simply passing urine into your clothes in the middle of a conversation without any attempt to stop it or recognition that it's abnormal, we term voiding dysregulation. And I've seen it twice in clinic, and both patients, one had dementia and we knew it, and one started to show features of dementia soon afterwards. The other one is involuntary voiding. So that's where you're talking to the person and they suddenly start to go, oh God, oh, too late. And that's not actually driven by urgency. It's driven by activation of the micturition reflex at the wrong time, outside control. So it's a void. It's not detrusor overactivity incontinence or urgency. It's involuntary voiding happening without regulation. Luckily unusual. It's basically, if you are experiencing urgency, you usually have lead-in episodes. Ooh, I've got to go. Hey, oh, I better go. And it might be a short time frame, like 2 minutes or so. There is a prodromal, but also they will squeeze their pelvic floor and try and resist it and find that quite uncomfortable. And they're really working hard to resist it. You can see that effect. Whereas voiding is detrusor contraction and outlet relaxation. So they just go, the outlet just goes without their command. So they're not resisting at all. It's close to automatic bladder, but it's driven by the context. So automatic bladder is usually a brainstem or that sort of level, and is, is what always happens. Inevitably, always, relentlessly, every single time, it's automatic. Here, it's a person who's walking about, living a comparatively normal life and experiencing occasional episodes. Yep, fair enough. There are various scales of urgency, and the 5 scale is a good choice. So to complete the neurogenic side of things, relevant neurological pathology must be present. I struggle a bit to think of an irrelevant neurological pathology, but there needs to be something neurological. So if people are getting these symptoms, you might need to think about screening for the neurological disease, because there are conditions where urinary symptoms or weird symptoms happen early in the process, perhaps before the neurologist has seen this patient and made a diagnosis. So that's just a repeat, and that's not really worth going over. So enuresis, intermittent incontinence that occurs during sleep. They stay asleep. And the key differentiating feature for enuresis compared with urgency incontinence happening during the nighttime, if they get urgency whilst asleep, well, you can't. Urgency is a sensation. You're conscious of it. You must wake up to be conscious of a sensation. So what happens with urgency incontinence is they wake up, perhaps they wake up very late. So the incontinence happens very soon after they wake up. And the key point is that if that happens, they will be aware of warm body temperature urine leaking into their night clothing. With enuresis, the urine is passed, but they stay asleep. Later, they wake up, and they wake up because the urine has now got cold, and they find they're in a cold, wet bed. So the key thing to decide if somebody is enuretic is to ask, do you wake up and are you surprised to find you're in a cold, wet bed? And that just tells you what's going on. So primary means this is present all their life, and that's the classic pediatric failure of potty training for the nighttime. But secondary is an enuresis, and this actually applies to adults too, where they had a dry period. So for the adults, this can actually start at an older age, like 50, 60. There are 2 things to think of in that case. One is it can be an early feature of cerebral neurological dysfunction. Secondly, it could be that they've developed chronic retention of urine. 2 possible mechanisms. So an adult male with a big prostate and a distended bladder, that's the chronic retention. Adult male or female with no distended bladder, think about dementia or neurological disease. So that worth reading. The footnotes are there included for comprehensive description. I think that's clear enough. Okay, so there is a formal definition for those 2 that we just discussed, the voiding dysregulation and the involuntary voiding. And to emphasize, they are related to activation of the micturition reflex at inappropriate times. Now, in a more detailed description of the neurological, I'm sure that we've all heard of this phrase, detrusor sphincter dysynergia. Now that, for the neurological patient, is a very, very specific circumstance. It can only happen when there is either a brainstem or spinal cord problem, which is interrupting communication between the pons and the sacral part of the spinal cord. And the consequence of that is that those two centers are not regulated as appropriate by the nervous system, meaning that they don't know how to behave, and they start fighting each other. And we'll look properly at a trace of detrusor sphincter dysynergia during the neurogenic talk. Quite similar, but the mechanism is different, is a non-relaxing urethral sphincter. And that basically means that the sphincter is constantly fixed, unchangingly consistent in its contraction, both during storage and during voiding. It simply never relaxes. So, to look at a trace, what do we think is going on here? Now, this is permission to void has been given here. Then you can see that there is some detrusor contraction. And then you see that after, well, look, 11 minutes and 10, 12 minutes and 40, they have been voiding for 1.5 minutes by this stage. Most people get a bit bored. They want this voiding to stop. I want to go and do other things. So a natural reaction, if you're trying to void and really not getting very far, you strain. So here there's very little straining going on, but at this stage, a bit of straining, a bit of more powerful straining. It's picked up in both the blue and the red line. And then they do really quite a powerful strain that actually pushes the vesical catheter fully out of the bladder. Not uncommon to see that happening in a neuropathic patient. So here we have slow flow, weak detrusor contraction. As we discussed earlier, that would be detrusor underactivity. It's taking a very long time, so they augment this underactive contraction. So you can see that, when they are not straining and the detrusor pressure drops back down to roughly this sort of level, doesn't it? So you can see how the squeeze is superimposed on top of the underactive contraction and has the effect of enhancing the flow. So this is straining to augment the effectiveness of an underactive detrusor contraction. Is that a question? Make sense? So you can't tell from this if this is man or woman. And this is the video image that goes with it. This is where a man has been turned through 45 degrees, so you can actually look at the proximal urethra. You can see the bladder neck is wide open and the prostatic urethra is opened out. There's no intrusive prostate. And therefore you can deduce that there is no bladder outlet obstruction. It's purely underactivity. So underactivity, slow flow related to slow pressure. There is actually nowadays also the term underactive bladder syndrome, a sort of counterpart to overactive bladder syndrome. And we came up with a standardized term where it's characterized by a slow stream, hesitancy and straining, with or without a feeling of incomplete emptying and dribbling, often with storage symptoms. This has not proved so useful. It was first developed because it looked like there might be medications available to develop to treat this, but those have been abandoned, and consequently, we don't really use underactive bladder anymore. Perfect. So that concludes the terminology section. Are there any questions about terminology? So we covered overactive bladder, intrusive overactivity, incontinence, bladder diary, weak bladder, straining, that sort of thing. Questions? So why don't we just grab a coffee? Perhaps a fun, please. Well, it's difficult as an adult urologist, so I don't see children. But that relationship between enuresis and difficulty waking up, I think it absolutely points towards a sleep abnormality. In which case, the treatment is to see a sleep specialist, not to see a urologist. And you work as a team. And that's what we would be doing in the UK. So for an adult enuretic, we would do a sleep history and we would send to a sleep specialist if we find that the sleep history is abnormal. Then you have to go and learn sleep medicine. And I can't teach it to you, but that's a serious point. I think it's kind of ridiculous, isn't it, that we are expected with our training as surgeons to go and handle something that is emphatically medical. It's even more specialized than neurology. And if you start to prescribe things that make them sleep more lightly, or various schizoaffective drugs and psychotics and things, antipsychotics. Exactly. How could you? Yeah. Which is clearly having no effect on the mechanism. How will that influence the mechanism? You're just hoping that maturity will suddenly flip them out of it. And I feel that's inadequate. And that's not a criticism of you. It's absolutely, there are not enough sleep specialists in the UK, and you have no sleep specialists. So, well, if somebody wants a a good career with plenty of rewards, sleep specialty is a very, very interesting and important thing. But making a diagnosis relies on sleep EEG and things like that, which obviously you have no access to. So my personal feeling is that you've got to be honest with your patient that the mechanism is not urological. Yeah, but you've also got to face the fact that if you fail to achieve improvement, it looks like you don't know your urology. But you do know your urology. What you don't know is your sleep medicine. But why would you? So if you're not clear to your patient, saying, well, you've seen me because it's to do with the urinary tract, but actually the problem is not in the bladder, it's in the brain. I'm not a brain doctor, but I will do my best. Please forgive me, because it's unwritten, because you all know that if you have a bad outcome from an operation, you are going to get criticism. Likewise, if they fail to improve their enuresis, unless you're clear to them, you will get criticism. You're also getting a phone call. So that would be why I'd really emphasize, you've got to be honest. I think that there's an issue to do with the maturation of a circuit in the brain. As a urologist, I can't influence that, but let's see if there's some practical, useful things that at least can take the edge off it. That's how I'd phrase it. Sure. And nor should it be. Will come. Let's come back to this. Let's come back to this. Let's just finish the tofranil. We still use tofranil in UK. Absolutely never prescribed by a urologist because of the reasons that you said. It is a highly specialized prescription. Why? Because the outcomes are uncertain, because the risks are high. You must not waste a good tool by somebody that doesn't really know how to use the tool, doing the prescription and just causing risk. It's a specialized thing. So to have it in our hands is inappropriate. So, I mean, it's a bit like if you prescribe a drug very, very infrequently, how do you get confident about it? Furthermore, 50%, that's in the idealized research setting. It is not 50% in real life. No way. So I think that you've got to be very clear to these parents who look at you saying, I expect you to cure enuresis. You've got to say, maturation. Your child needs to be fortunate and mature the circuit. And they're usually women, not always, some adults who have primary enuresis, and they're just simply trying to cope, trying not to stay in other friends' houses or whatever it is. It's a nightmare for them. So I don't treat children. The youngest patients that I see are the transition patients going from pediatric urology to adult. Pediatric urology is a separate specialty in the UK. So I'm afraid you'll have to answer that. I don't see children. So I'm sorry. But what was your point? So it's basically forcing them to reset their sleeping habits, I guess. But what age are you referring to? 10 years. So not baby, young adults. Yeah, absolutely. But I see as adult urologists the circumstances where that has not worked, because it does not always work. It's not inevitable that the situation matures into normal function. It's very frustrating. Okay, so I suggest we have a 10-minute break, and then we'll have 50 minutes up until lunchtime.